we're coming to the end, but this is an important topic, so I'm going to take us through. I do have a few disclosures, some consulting that I do. By the time we're done, I want you guys to be able to look at this x-ray and not freak out and go, oh my God, what do I do with this? Or this one, which one of my partners left me to just wash out on a Saturday, left out a few details. But we're going to come back to these cases because if you can stick to the principles and know your anatomy, you can definitely deal with these. They're not that bad. The goals for this lecture is by the time I'm done, I'd like for you to be able to describe the normal anatomy, know what are the appropriate radiographs to order, select the appropriate treatment modality, the road you're going to walk down with the patient, and initiate rehab protocols for these patients with distal radii and forearm fractures. The anatomy, I think, is really important here, and so we're going to take a moment and spend a good bit of time. This is an AP of a wrist, and you can see I've highlighted the scaphoid and the lunate, as well as their respective fossas on the distal radius. This is important because if we want to restore normal anatomy and function, we have to know what normal is, and there are particular relationships that we're looking for. Well, why is that important? The wrist is a very mobile joint, and aside from the bone, which is very important to me, are these structures. And what we need to take away from this particular slide is that the ligaments that go from the radius to the carpus are attached to the bone. Duh, we learned that in basic anatomy. But when we have fractures, those ligaments are still typically attached to the bone. So if we don't fix the bone, if we leave those little tiny fragments without any fixation, the hand is going to fall off. And that's where we really get into trouble with the distal radius. So how do we evaluate the fracture? Well, we typically start off with a 3 view of the wrist. Some surgeons are a little more aggressive about getting CT scans, but typically we reserve those for the exceptionally comminuted fractures, or those fractures that involve the volar lunate facet, because that's where most of the money is on getting the volar radial carpal ligaments back into their home. If you're concerned about a disruption of the scapholunate interval, you need to go ahead and get clenched fist views or deviated views to look at the scaphoid and the SL interval. AP and lateral of forearm x-rays come with all distal radius fractures. Why? Because the forearm and the wrist really make up a circle, and you can't break one without breaking the other, except in rare instances, which we'll touch on in a bit. And then we don't want to forget the AP and lateral of the elbow because that too is part of the same circle. And we're going to talk about why that's important in just a moment. But when we look at our radiographs, what are we looking for? Well, we're looking for these relationships again. And on the radius, we see this classic radial inclination, and we're looking for about 23 degrees plus or minus 5. We figure this out by drawing a line down the axis of the radius, then perpendicular to this at the joint line, and a second line that's subtended to the styloid. We also want to look at height, and this is telling us whether or not there's impaction or comminution, looking at the difference between the styloid and the lunate facet. Typically less than 9 millimeters is a sign that there's some problems. And finally, on the AP, we want to look at ulnar variance, and this is really important because if you have comminution, you need to know what's normal for the patient. And the reality is that ulnar variance can be positive, the ulnar can be longer, it can be neutral at the same level as the lunate facet, or it can be negative, and the range is between 9 and 12 millimeters. So if you have comminution and you don't know what normal is, get an x-ray of the other side so that you know how to build back that patient's normal anatomy. On the lateral, we're typically looking at volar tilt. And our average is right around 11 degrees with the somewhat 10 to 25 degrees in range. And we can, though, occasionally see dorsal tilt, but usually less than 5 degrees. And again, we draw out our lines here and we take a measurement. I'm coming back to this image because it's important. Because I want you to walk away from here understanding that it's not just the broken bones, it's the ligaments attached to it. And this is why. So why do we care about the ligaments and the small fragments? Well, the arrow is showing us this really tiny little fleck of bone. And probably most of us are keyed in on the fact that this hand is falling off of the wrist. Well, why is that happening? We're focusing on the big fragment, the articular fragment. Really what we need to do is get that tiny little fleck of bone that has the really important dorsal radial ulnar or radial carpal ligament attached to it. And if we don't do that, we failed the patient. So how do we treat these patients? Our options include both non-op and operative. Non-operative management is typically reserved for our lower demand patients or patients that have less than 2 millimeters of articular step or gap, radial shortening of less than 3 millimeters, or dorsal tilt of less than 10 degrees. We have predictors of failure. So you get this fracture in the ED, you go down and reduce it. What's going to predict whether or not it's going to fail? Well, age. Comminution makes kind of sense, right? Higher energy, more unstable, length unstable. And this is one that we kind of look over as the volar reduction, or the ability to get the volar cortex to line right up. But that's actually the most important one. So when you go down to the ED and you reduce this, if you look at your post-reduction films and the volar cortex isn't pretty much anatomic and lined back up, there's a good chance that that's going to fail. And that's important because that's part of the conversation you get to have with your patients. Volar plating tends to be the workhorse. We reserve this one for probably 80–90% of our fractures. We want to get our screws right along the subchondral bone. They can be locking. We do want to make sure that we don't stick them out long on the dorsal cortex because that can be associated with tendon rupture. Dorsal plating is another question, right? I've already shown you this example here. When do we dorsally plate? The simple answer is when we need to, but really it's when we see this dorsal comminution, when we know that we have to push that bone back into its home. And that's what this looks like here. That plate is put there specifically to push the dorsal comminution back in its home. Why is that important? Because it's got the ligaments attached to it. And now the hand is sitting in its home. We see this patient 10 weeks later. He's back driving his cab and he's doing pretty well. Combined volar dorsal plating is a little bit more difficult, and this one is sometimes a decision that's made intraoperatively. This one is sometimes the one you're thinking about when you go, you know, I don't really know exactly what's going on there. I see some comminution. I need to get a CT scan. And if you look at this image, boy, I need some coffee. I got the shakes. You can see that there's about 3 different fragments here at the joint surface. And you say, you know what, I'm going to give this a go. I'm going to try and do this all volarly, and I'll just capture the dorsal comminution. And as you do that, you look at your images critically, and you can see that the carpus is still trying to escape away out dorsally. And you can see that there's still a little fragment here. And again, this is where your knowledge about radiographic anatomy comes into play, because a line down the center axis should bisect the lunate, and it's not. So we go ahead and we add a dorsal plate. We've got combined volar dorsal plating, and now the lunate lines up where it's supposed to be. So what about this one? Well, when you see comminution this extensive, our brain really should run to concepts of relative stability or spanning fixation, and that's exactly what we did in this particular patient. This was a staged modality, but you can see the X-fix pins here. Sorry, the pins are cut off down here. But we have spanned this area, and this is a great damage control modality for open fractures with extensive comminution soft tissue injuries, and it also gives you a chance to take a breath and think about what you're going to do for this patient definitively. I need you guys to be aware of the acute carpal tunnel. Carpal tunnel occurs between 2 and 21% of the time. You'll recognize it as sudden median nerve symptoms that do not go away once you reduce the fracture. It is a surgical emergency, and it's more common with greater than 35% displacement of the carpus. But if you miss this one, the patient's life's changed forever, so don't miss it. Rehab protocols, these are a little bit variable depending on the extent of the comminution and surgeon preference, but we want early motion, at the very least of the fingers and elbow. We want to work on edema control with elevation and ice, and typically we'll allow the patient to weight bear for ADLs. Some folks will use a splint for 6 weeks, and again, that's typically reserved for the more comminuted fragments or the patients that quite can't be trusted. We're going to move on now to the forearm, and we're going to start again with anatomy because anatomy is king here. Number one, we have to recognize that there is a radial bow both in the coronal and the sagittal planes. We have to restore that to normal in order to regain pronation and supination of the forearm. Most of us need about 100 degrees in either plane to accomplish our activities throughout the daily life. We need to remember that there is a joint, both at the distal radial ulnar joint and the proximal radial ulnar joint. We have to look here for concomitant injuries. And then we can't forget the interosseous ligament that was mentioned just a moment ago, because disruption of this does create instability. So let's talk about the rarities, the isolated ulnar fracture. These occur typically from a direct blow. They're actually also called perifractures. The nightstick comes from the old days when police would carry nightsticks and go after people who were breaking the law and hit them. They put their arm up to parry the blow away, and they get a direct blow, typically described through the middle 2/3. And if it's displaced less than 50% or 10 degrees of angulation, it's perfectly amenable to non-operative management with an ulnar gutter splint. This is what we classically see, though. This is your classic both bone forearm fracture. Some form or variety of simple or comminuted fracture. We move forward with operative fixation because this is a fracture of necessity. Both bone forearm fractures need to be fixed so that we can restore motion in the forearm, put the hand in space, as was mentioned just a moment ago. Sometimes they come in a little more comminuted. The treatment's still the same. You restore the patient's normal anatomy, recognizing that there's radial bow in both planes, and in this particular case, you want to get an x-ray of the contralateral wrist because I have no idea, based off of the injury comminution, what the ulnar variance is. And that's important so that you can avoid the patient having unnecessary pain in the wrist. This next slide is really important. Isolated fractures of the radius and ulna are relatively rare. I said that just a moment ago. It's usually a direct blow onto the ulna. So if that's true, and we see an isolated fracture of one or the other bone, we always need to be looking for the associated injury. If you take nothing away from my talk today, if you see an isolated radius or ulna, go hunting for the other injury. If it's a distal radius fracture, more commonly extra-articular, there's very commonly disruption of the distal radial ulnar joint here. And you can see that on the injury x-ray. The radius is no longer talking to the ulna. Here's another example. This is a little bit more mid-shaft. I'm not always thinking about the distal radius on this one, the distal radial ulnar joint, but I know that I have to go looking for it. And if you go looking for it on your fluoro views, look at how wide that thing is. So the first order of business is to fix the bone. If you fix the radius and then test the DRUJ, if it's stable, you're done. You leave them alone. If you test it and it's unstable, but it reduces when you supinate, which is the position of stability, then you splint the patient in a position of supination. If you fix it and it's just all over the place, you have to pin it, typically with 2-0 pins, typically 2 of them in case one gets loose, and then you either splint or cast them for a period of about 6 weeks. At 6 weeks, you get the splint off, you get the pins out, and you get them moving to preserve function again. Put that hand in space where people want it. As we move up to the proximal radial ulnar joint, you heard a great lecture about the elbow just a few minutes ago. And the PRUJ was mentioned, but it doesn't always have to be ligamentous. It can be fractures of the proximal radius as well. This is still technically a both bone forearm fracture, although we lump the Monteggias into sort of complex elbows, and that's because it is the elbow complex. It is a disruption of the proximal radial ulnar joint at the level of the elbow. What do we do for these fractures? Well, we restore the bony anatomy. We keep going the same way as we always have. Anatomy is king. Get the anatomic reduction of the ulna in this particular case, and then we went ahead and fixed the radial head, which was the underlying pathology. But it doesn't always have to be a radial neck fracture, something where the head is falling off. It can be purely ligamentous. It can be a small head fracture. But when you look at the lateral image, you see that the radial head is anteriorly subluxated out of the radial capitellar joint and no longer talking to the lesser sigmoid notch in the ulna. So we know that this is involved. In this particular case, this is that same patient from before, you see that there's also disruption all the way down through the interosseous membrane down to the DRUJ, and that's what an Essex-Lopresti is. It's disruption all the way across the interosseous membrane from proximal to distal. With forearm, you have to look out for the compartment syndrome. It's just like the distal radius. It's a carpal tunnel in the distal radius. In the forearm, we just call it compartment syndrome, and it's the second most common site. So if you have a patient with a forearm injury, you've got to educate them about it. You've got to make sure your nurses know to look for it, and you've got to be looking for it. So this brings us back to this other patient. What do? Well, we know the anatomy, right? We know that anatomy is king. So let's go ahead and restore her normal anatomy. We've got to get the elbow back together. We've got to get the forearm out to length. We've got to make sure the relationship between the radius and ulna is anatomic or as close as possible. In this particular case, deal with the bone loss, but we're able to do so, and you get a pretty decent result. So in summary, be a master of anatomy, whether it's this or any other aspect of orthopedics. If you know your anatomy, you can work yourself through most injuries. Obtain full and appropriate radiographs. Understand what the normal anatomic relationships are. Treat fractures in a way that restore the normal anatomy so that you can get them moving and rehabbing as quickly as possible. Begin those rehab protocols as soon as you possibly can, and if you stabilize them well, and you recognize and treat the soft tissue injuries, you can do so in a timely fashion. And don't miss compartment syndromes or acute carpal tunnels. Thank you.
Don't go anywhere. But you can stretch. Does anybody have any questions? So we had some great talks on upper extremity fractures and some really common things that we all see in the emergency room or take care of. Any questions that y'all have? No? Yes, Dan. Question is okay. So question is, what are some tips and tricks that I'm going to ask probably Diane to answer this question? And we don't have cordless mics, but kind of some tips and tricks to look for some subtle findings on elbow x-rays, distal radius films, those kinds of things.
You know, I think that's an excellent question, because how many of you order x-rays and they're all obliquograms? So, you know, this is the biggest frustration I have, and literally unless you're going to be present with the radiology tech to get those perfect views, it's going to be very hard, and you're trying to piece it together. So one of the tips is get as many views as possible. If it's typically on a long bone, it's 2 views. On a joint, it's 3. Ask for 2 obliques, all right? If you can't be there yourself, get more views, because then you can piece it together better. But you know what? I live in Canada, and we can't spend a lot of money, because the government pays for all of that. But you know what? I get a CT scan. And I think that's the only way to really make sure that you know where those fractures are. So a really low threshold to get advanced imaging if you have any doubt. Okay. Anyone else? Does anyone else do anything differently?
I have a question.
Yeah.
You mentioned one of the big side effects of elbow fractures, whether they're interarticular or extraarticular, is stiffness postoperatively. Any tips for our patients with getting them moving more easily post-op?
Yeah, also a great question. So stiffness is something we all battle with when we do elbow injuries. And so first of all, during your surgery, make sure you irrigate out the joint as much as you can. You know, make sure there's no bony debris and you've obtained meticulous hemostasis. A lot of times, I typically don't do this operation with the tourniquet up. I have it around, it's ready to go, but I do everything without the tourniquet because I want to get the the bleeding under control. Bleeding, bone debris will add risk to HO. So you don't want any of that forming early because that's a mechanical block that you can't get away with. Once that fluff of bone starts, it's very, very dangerous. Now, if you don't have to deal with HO and it's just soft tissue contracture, the key is just getting them moving early. So adequate analgesia at the beginning and making sure that you educate the patient before the surgery. You tell them, it's going to be painful. I'm going to make you move. Get your physiotherapy appointment booked for the day after surgery. So the goals of surgery is to allow you to do that. So make sure, I'm not a big fan of long arm plaster splints. One, they're very heavy. Two, it actually deforms through the fracture because everybody, even though you tell them not to do this, they do that. And so the plaster never goes on quite well, and it ends up all in the forearm. And this is what they end up with by the time they come back to the clinic. So what you want to do is give them something very light, or just put them in a sling, and make sure that you get them moving early. And a hinge elbow brace is sometimes helpful, not necessarily because you're worried about the ligaments, but it gives them a psychological security, and you unlock it and you just let them go. And you have decided on your stability intra-op. Hope that helps.
I'm going to ask you one more question. How about prevention of heterotopic ossification? Do you have a protocol that you use?
Yeah, so I typically will not HO prophylax. If I do, it's going to be with Indicid for 3 weeks, 25 milligrams TID. Some evidence has shown that that doesn't really make a difference now. I don't use radiation, and I typically wouldn't prophylax after an acute fracture. My thought is I'd rather deal with stiffness, which I know how to take care of as a secondary procedure, than a non-union. Now, non-unions in this area are typically rare, but when they happen, they're very bad. So my option is just to do what I've mentioned already. I don't routinely prophylax, but if you are going to, then Indicid is probably my recommendation.
Other questions? Jason, how about those patients that have symptoms of acute carpal tunnel syndrome, and then you do a reduction? How long do you sort of wait to see if those symptoms are going to resolve, or what do you do with those patients after a pretty successful, you would consider a successful reduction?
Yeah, I think that's a great question. I don't give them that long, usually about 15 or 20 minutes. They usually respond pretty quickly once you get the pressure off the nerve.
Okay. Yeah, Dan.
So one other point around the elbow, this kind of goes back to the lectures this morning about open fractures, but a lot of times we'll see some of these complex elbow injuries splinted and transferred in from another facility, particularly if you're at a higher level of care. Take the splint down and be really, really suspect about a punctate open injury, particularly in some of these elderly patients with poor skin. One of those little spikes of bone from the proximal ulna or from the lateral aspect of the distal humerus will puncture through, and the outside facility may not even notice it. But you take it down, and if there's any hint that that's there, that's something you need to be really cautious about. And a lot of times the CAT scan will show you some free air around the fracture, and then that's obviously the telltale sign. But since you're going to be on the front line, so to speak, with these types of injuries, have a really high index of suspicion for that being a problem, because it definitely changes your treatment algorithm.
I think that's for anyone that's at a facility that people are being transferred to a higher level of care. I don't know. I don't care if it's upper extremity, lower extremity, ankle fractures, foot fractures, whatever. Take down whatever dressing or splint is there and look for yourself before you admit them or send them home or whatever you're going to do.
I mean, the people will frown on you, and there'll be family members kind of wondering why you're doing that, and it may actually cause a little bit of discomfort to the patient. But it's just routine. It's something you need to be doing.
Jason, how about post-op? What do you do with your both bone forearm fractures? Say it's a standard, it's not the x-rays that you showed to begin with, but your standard sort of both bone forearm fractures, distal radius fractures, what do you do with them post-op?
Yeah, so soft dressing and full range of motion, weight bearing for ADLs. I don't restrict them. They all leave the hospital with a script for therapy.
Great.
I totally agree with that. I think if you're going to fix the forearm, you don't put a cast on that. You let them move right away. One of the other things that is not emphasized about forearm is sometimes the hand. So they'll do this, but they'll do nothing with the hand. And FPL scars down like crazy. So